could I ask you to read the mission statement and vision? Could everybody be seated, please?
The NGH mission statement is to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into practice.
Thank you. And we'll give the members opportunity to disclose any potential conflicts or belief that they can be unbiased and able to participate, or if they elect to recuse themselves from any matter. None mentioned. Do we have any public comment?
There are none.
Okay. Dr. Elders has some recognitions to make.
Good afternoon, Chair and fellow board members. So just a little history. I'm going to recognize two. We have four, but I only see two present in the audience. During Nurses Week, we started last year recognizing a nurse leader for exemplary leadership. We call it the NALA Award, and if you walk in my office, there's butterflies everywhere. And the reason I love butterflies so much is because change is the essence of life. You have to be willing to let go of who you are for what you can become. And so you'll see them everywhere. I wear them everywhere, and so I give them out also. So the first person I'm going to recognize is Dr. Joshua Baxter. He's the Clinical Director of Perioperative Services. Dr. Baxter's outstanding leadership in steering our perioperative services through significant change this year, it has been remarkable. It was a tough year, and he just took it all in stride and facilitated a seamless process that has proven to be invaluable to the hospital. Dr. Baxter, could you please come and get your butterfly? Thank you. The second leader I'd like to recognize is Ashley Midkiff. She's the Clinical Director of Emergency Services. With the No Wait ED project last year, she probably could have strangled us, but she did a really excellent job in driving change and encouraging teamwork, reducing her door-to-bed time in the emergency department from 25 minutes to 4 minutes. Ashley, please come up and get your butterfly. Thank you. There are two other leaders. One is Ashley Mancini and Chelsea Napier. They could not be here today, but I just mentioned them, and they are in your packet if you want to read a little bio on them. Thank you for this moment.
Thank you, Dr. Elders, and congratulations, Dr. Baxter and Ms. Metcalf, and I trust that we have many more butterflies among us that we can look forward to being introduced to in the future. The minutes of the April meeting have been distributed to the board members and reviewed by our secretary.
I'd like to recommend that they be accepted, please.
Been recommended and seconded. Any discussion about the minutes? All in favor of approval? Aye.
Aye.
All opposed? Motion passes. I call on Mr. Esquivel and Dr. Elders and Ms. Lewis to give an appropriate report on the status of the PSA negotiation.
Thank you, Mr. Chair. I'm happy to start, and we'll then defer to Dr. Elders shortly thereafter. There have been two PSA meetings between Meharry and the hospital since our last meeting. I attended the first of those meetings and can report very happily that they continue to make significant progress. There are all-in meetings that happen, and in between specific subject matter committee meetings to address in particular the financial aspects of the PSA and physician recruitment. And so there's the meetings are very productive. They are still working towards a July deadline, which was an aggressive deadline, but appears to be on schedule. And so the board can be confident that from what I have seen and what is happening in those meetings, they are proceeding steadily and making good progress. And invite Dr. Elders to share more detail.
Sure, thank you, Mr. Escovel. We did have a meeting on yesterday in regards to the PSA. One of the big questions in that meeting is, are we going to meet the July 1st deadline? And we did have a commitment from both organizations that we really want to work toward that goal. We have now moved on from the main draft to looking and crafting criteria for the exhibits. And so that is great progress. Dr. Bullock has taken the lead on the Joint Hire Committee, and Dr. Blacklish has taken the lead on the Finance Committee, and they have subsequent meetings scheduled between that time and our next meeting for the PSA, I believe, is June 11th.
Thank you for all your hard work in that. I'd just like to point out that we're in a new era with a lot to look forward to. But this PSA agreement is the first step before we can move forward for future plans for the hospital. So I appreciate the speed with which you're moving after struggling with this for a lot of years. The next call on Mr. Smith and Christy Lewis to discuss the conflict of interest.
I'm aware of this item was announced to explain the last meeting. As I'd explained at the last meeting, we used a separate attorney than myself to dig into the weeds on this, and he worked with Ms. Lewis, so she really has the more direct information. And I did an overview on it, but I think it's a satisfactory form as well as a policy.
Thank you, Mr. Smith. I've worked with Mr. Hall and Metro Legal, so we have our conflict of interest that is ready for submission and for application. In that conflict of interest, as we've stated before, is when you have outside interest or activities from either a board member, employee, or a volunteer that impairs or influences that person's independence or impartiality to act on the hospital's best interest. And as a result of the conflict of interest and ethics policy, it is 5 pages, and it talks at its scope. It has definitions in there where it has a covered interest, compensation, defines what a relative is. It provides the guidelines for the conflict of interest, a code of conduct compliance, and a section that deals with procurement of goods, services, and construction, use of information, falsification of authority of documentations. There is a section on gifts, entertainments, and favors, as well as finally the conflict of interest disclosure form. What is different about the disclosure form is that it is not overly expansive. It is not intrusive. So we have reduced that down to 9 questions where it was previously 13. So about several of those questions that were overly expansive and were not really necessary. Are you getting to the heart of the conflict? So if you have that in your packets, I would welcome you to complete that today. And if there's a question about how it's going to be stored, it is going to be stored on a shared drive to which only I would have access. It is not going to be used or leveraged for any information outside of the purpose of disclosing that. So that is how that's going to be done. In terms of the hospital, it will be administered on an annual basis to all those in leadership capacity. We will keep those and disseminate them and collect them also and keep them on a shared drive to have accuracy for that as well. Are there any other questions? Any questions?
Any questions for Ms. Lewis?
Can I state, I will print the forms out so you can have an individual form. They're actually bound in the packet.
Oh, okay.
So I will go print them and distribute them in just a moment.
Thank you.
Ms. Lewis, is the conflict of interest form ready for approval by the board?
Yes, sir, it is.
I would entertain a motion.
So moved.
Is there any discussion about this? It's been a long time in the working, and we've had plenty of opportunity for any questions, but any further discussion? If not, we'll call for a vote. All in favor, sign by saying aye. All opposed? Motion passes. Thank you.
Might I also recommend that this become part of the new fiscal year process, and so annually that we make sure that we are signing this document, and obviously part of any new board orientation process. Mr. Chair.
Absolutely. I agree. Another thing to put on our calendar.
Is that eligible for a motion or just a point for moving forward?
I think it's a point for moving forward, and I've worked with Janet to develop a calendar so that our budget, our election, our CEO evaluation, and this are all on the calendar. Thank you. Do we have a marketing report? There's Kathy. Thank you.
Good afternoon, everyone. Just with all the changes, I wanted to give you a brief overview of the marketing department as it stands today. So right now, we are now the Marketing and Patient Experience Division. The core functions are media relations, public affairs, crisis communication, brand management and creative services. That's handled by Kaylin Harris. Communications and external relations is Chanel Lake Doxey. And then provider and community relations is Simone Johnson-Jones. And then the patient experience manager, that position is actually in the process of being hired for. What's important about bringing all these roles together on the second page is the number 3 under the patient relationship cycle. I was talking to Mr. Lesser earlier. You know, none of us would be in this room if it wasn't for patients. Everything we do, every decision we make is how do we treat patients before they even walk in the door, when they walk in the door. I'd love to be the Savannah Bananas of healthcare. I don't know if you've been to one of their baseball games. They just sold out Titans Stadium. I've been following their CEO for a couple of years on Instagram. They took a non-existent baseball team in Savannah and have turned it into 4 different baseball teams that now travel the country, selling out NFL stadiums. I'm not going to say we're going to get that big, but we are the only city hospital in the healthcare capital of the United States, and we should be at that same level, just from that perspective. So the patient relationship cycle starts with awareness. Our digital presence, our marketing, the referrals from outside doctors, referrals internally, our community involvement, and our patient relations. Then it goes into consideration, the response to the communication, personalized interactions, ease in scheduling, telehealth. How do we engage what would be our would-be customers? Then the conversion, getting you from being a patient to actually being a customer, the quality of care, exceptional customer service, transparent pricing, patient education. To retention, the personalized follow-ups, shared decision-making, patient portals, the surveys and the feedbacks, the voice of the customer is extremely important. And then finally, the advocacy, addressing concerns, the personal touch, the loyalty to our brand and who we are, continuing education, and how we show improvement. And we do that through each division within marketing, believe it or not. So the next page shows the branding and awareness. This is Kaylin's forte. She does an exceptional job with pulling together whether it's Nashville General Hospital, you'll see more of the light blue to the gold. If it's Nashville Healthcare Center, it's mainly the teal and the green. If it's all through 2 organizations, you're going to see more of the Metro, what I call Metro Blue, because I feel like we are still Metro. I wanted to pull that color in there. all the way through the lighter blue, the green, and then the gold. And those are just some of the examples of collaterals that she has created for our organization. In the middle section is our social media performance. This is comparing July 1st of 24 to May 15th of 25 versus the 23 to 24, so a year back look from prior year. Our audience growth has jumped 38.3%. Typically, you're between 6 and 24%, so pretty strong in that area. Little dip in impressions, which is the number of times we're seen anywhere within our social media platforms, organically, or even just people who are on our page. We took about an 8% dip from prior year, but what's interesting is our engagements are up almost 67%, and our engagement rate per impression has doubled to 3.1%. And a typical engagement rate per impression is 0.5 to 1.5%. So I think Chanel's done a great job since she took over on the social media side. And then the images to the right, those are actually our top engagement rate posts in the last year. And what we have found is, especially when we're putting people's faces who work at the hospital, those are going to get us our highest engagement rates. And the other interesting thing, it's not Facebook and Instagram, it's Facebook and LinkedIn. LinkedIn, actually, we have a lot of engagement on that social media platform. Just turning the page, I know it's a lot of color, can drive people like Melanie Thomas, where is she crazy when I do this, but this is our practice liaison and community outreach. We bleed between what Simone does, being out in the community at all of our external sites, getting feedback from them, working at community events, with what Chanel does where we're out doing sponsorships or promoting health screenings along those lines. So each of them I color-coded because Simone's done a great job connecting with some of our metro agencies. So Yellow School Bus, everything is yellow, is with MNPS. So it's twofold. It's actually when they have parents and in the community there, but also for the teachers because of that Metro Healthcare Incentive Program. MNPS employees can come to General Hospital without incurring copays or deductibles. Next, you have the community sponsorships and partners. Most of those items you'll actually see on the calendars we provide. And then we also have been looking at the towers where our Medicare population is. So Simone goes out there and meets with them and brings providers to them. So you'll see a couple of events, whether Heart Month, we had Dr. Kelly there. We've had Dr. Smith Francis, our midwifery chief, going through there, as well as Dr. Pierre. Everybody loves Dr. Pierre. He is one of the most engaging providers. He is our foot and ankle specialist. And from being on 92Q, they have a Ask the Expert during the Kenny Smooth show. If anyone's up early enough, you will hear some of our providers on the show. They brought him back to Pearl Cone so he could do the white coat ceremony for their graduate, the high school students, earlier this month, and that was a great connection to have. So just wanted to show you we're in a lot of different places and out in the community, not just here in the hospital. And then, of course, just for the next 3 months, you can see we have our cancer survivorship event this Sunday, which is usually a great celebration here. Our Kids is having a hammer down race that they had to reschedule from May. It is June 7th. Down in, I don't even know what we call it now, Germantown, but the Riverside, River North, is that the new name? J.E. Dunn at their location. And then we do participate in the Nashville Freedom Festival. You will see the highlighted boxes in red. Those are our engagement surveys. So we have the employee engagement survey that will be kicking off in a couple of weeks. And then everything from board meetings to other events that we're participating in. And then also a couple of I had shared a RFP, a draft RFP with a couple of the board members. I will be sending that out to the entire board just to get feedback. I will not be at the June board meeting. I'll be out of town, but it's something I'd like to bring back to the July board meeting. So once I send it out, if I can get some feedback on any suggestions or edits and get that back, then we can go live with that in July. Any questions?
Thank you, Ms. Poole. It's really encouraging to see so much that's being done by our own in-house team.
Yes.
And congratulations on pulling all this together.
Okay. Thank you so much.
Next, I'll call on Dr. Bullock to update us on medical staff bylaws and give the credentials report.
Good afternoon. Just want to give a bylaws update. We have had a couple more meetings since our last meeting here. We have established a really good cadence going forward. I think everybody is on board to hopefully get these done fairly quickly. We want to be able to make sure these go to the annual medical staff meeting in August. So that does kind of shorten our timeline because we do want to have a draft that is able to be printed and be available for a review prior to going to vote at that meeting. So everybody is doing really well. We've kind of increased the cadence. We're trying to do it about once a week for a shorter amount of time. Gets a little bit exhausting to do it for 3 hours at a time. So that is the medical staff bylaws update. And if somebody has the credentials report, I'm happy to give it, or if Dr. Miller's not here.
Dr. Miller couldn't be here tonight.
Okay, does anybody have it? And I'm happy to give it. All right. So we have a couple new initial appointments. We have Clayton Harris. He's in emergency medicine. Dr. Henry Young in OMFS. Kaylee Connor. She's a women's health nurse practitioner in emergency medicine for the MLE team. A few reappointments. Miss Lisa Bolton. She's in internal medicine. And we had a few resignations. Catherine Largent, NP. Rex Sparks, NP. And Laura Klein, FNP, and Zach Booms, DO. All of those were from the ED. They were all PRN staff who have essentially moved and taken full-time jobs other places. Dr. Francis from anesthesia, his contract ended with North Star, and Dr. Monica Davis relocated to a new practice opportunity. And that is the medical staff credentials report. Are there any questions?
Any questions?
Thank
Would
you.
you like to proceed with the quality report?
Sorry, I'm sorry.
Oh, I'm sorry.
I'm sorry. Christy's doing quality.
Okay, fine. I would entertain a motion to approve the credentials report.
So
Second? Been moved and seconded. Any discussion? All in favor? Aye. All opposed? Motion passes. Thank you.
Afternoon, I'm Christy Lewis, Chief Compliance Officer, here with the privilege of presenting the quality report for Nashville General Hospital. I'd first like to start with highlighting that Nashville General Hospital has maintained its Leapfrog A grade status. Leapfrog provides hospitals the opportunity to submit information on processes as well as outcomes, and they then Leapfrog then provides a letter grade based on how well that status is. And I'm pleased to announce that Nashville General has maintained its A status for this season. Nashville, there are 5 hospitals in the Nashville area, and Nashville General was one of the 5 to receive an A. So I did like to make that announcement. I'd like to move on to the first goal of safety and care. The first thing that we're going to discuss are patient falls. On patient falls, there is a benchmark of not having any, and Nashville General did meet that goal of not having any patient falls. The second thing is on hand hygiene. There are 2 components: the compliance rate, whether you actually washed your hands, and then there is the observation rate. Now, for the compliance rate, hand hygiene, we had it of 95%, 95%. We did not meet that goal. We made 94%. Here is how we're going to remedy that. We're going to have more coaching opportunities. There are going to be greater observations, and we're going to maintain the increased notification so that we will make that 1% for the next month. However, for the actual, that is, did you actually wash your hands? Now, for the second component of did you have opportunities for coaching for that, we more than exceeded that. The benchmark was 585. We had a number of 773. So we do well on the coaching part of it. We do well on the teaching part of it. Want to make sure that we have that 1% more to make sure that we actually wash our hands. So that's another part that we have on safety. One of the more important things that we have is the barcode medication administration. That we did meet our goal. We had a benchmark of 95%, and we did make the benchmark goal of 96%. And that's important because when we have our bar medication, we want to make sure that we have the right patient, the right medication, the right administration. And so we do have a very good goal of exceeding that with 96%. I'd like to move on to our quality goal, our second goal, which is quality of care. And Nashville General Hospital has met all of the benchmarking goals with no incidents on the central line association bloodstream infections, the catheter-associated urinary tract infections, C. diff, colohyst, and C-section. We had met all benchmarkings and had no incidents for that. For the third goal, timely and effective care. And this is pertaining to two areas that we have for severe sepsis and for cesarean births. And we have on there that there is a data lag for both, but this is what we've done to mitigate the data lag for those. In the area with severe sepsis, we have been able to identify areas of bundles, if you will. Bundles meaning that there are sequences of when you identify a patient that has sepsis, are you following the sequences of orders that is required to treat that patient? If you have a fallout from that bundle, that means that there is a deviation from that sequential of order. So we have been able to mitigate not being able to get that out of our Cerner reporting by doing the charts, the individual chart reviews. And so we have been able to have several different, we had increasing numbers. The benchmark for the severe sepsis is 50%. But in doing the actual chart reviews, we have been able to show that for January, we did have 15 fallouts with 18 septic patients. That started us at 16.67%, and we have been going up steadily since. For February, 6 bundle fallouts with 11 septic patients increased it to 45% compliance. In March, there were 12 bundle fallouts with 25 identified septic patients that gave us 50% compliance. And with April, we had 8 bundle fallouts out of 11 septic patients, which gave us a percentage of 72% compliance. So as you see on a gradual basis, we have been able to increase it, and from the manual chart reviews of that, we were able to exceed for the April amount the 50% mark. We do intend a special thank you to the quality department for all that they have done in terms of the manual procedures, and we will continue to work to get the actual numbers from our Cerner reporting. The second thing is cesarean births. Again, that has a data log, but we were able to talk directly with our neonatologist as well as our OBGYNs to talk to them to say, do we have any incidents? Do we have anything as well? In terms of looking at our RL6 reporting notifications, and we had none for April. I will then move to goal number 4, which is dealing with our patient-centered. These are dealing with our press gaining reviews on that information. And I can say from the press gaining reviews is that we do have a benchmarking of 30, and that has been increased. That has increased from March to April from 7 to 18, so that's nearly double. But all of our other ones that we have had decreased numbers with. We do work with another department to get that number, to get these percentages. I do not see any of those representatives here. However, if there are any questions, I will be happy to take them back and to provide thorough responses to the board. I'm not able to give any more information regarding that for Press Ganey. I will go to the other one where it talks about staff engagement. This is dealing with the survey. We did have a survey that was the results for the survey that came out in October of 2024. We will have a survey that will be done this summer, and we presume that we will have the results around the same time, around this in October of 2025. And that's why we do not have any numbers before then. And as far as dealing with the regulatory or the goals of regulatory, I will defer to Dr. Elders to talk to that.
Yes, so first I do want to add, I want you all to know that Christy Lewis did just now take over quality. I want to say right before she went out for surgery last Friday. Now, she's here at this board meeting presenting, but we told her to stay home, but she's here. So I appreciate her valuing us enough to do that. But we did have the state come in for two. One was a PED survey, which is where they come in and they look and they assess you for your pediatric care. And so we're still waiting on the results of that. But we also had the state come in about three things. One was a fall with injury. Another one was a retained surgical item during surgery. And the third complaint was a billing complaint. But I am happy to let you all know that while they did provide us some suggestions for our recommendations for improvement, there were no findings. Okay.
Thank you, Dr. Elders. And that concludes the report on quality. Are there any follow-up questions?
Mr. Chairman, not a question. I think it's a repeat of something I said at an earlier meeting where these percentages for the benchmark, I know they're part of a national input, but we ought to make those numbers higher for us. 72%, 68%. I mean, in fact, in the responsiveness of staff on at least two occasions, that number was beaten by 35%. So we can do better than the national numbers, and we ought to shoot for that if we can. Thank you.
Could I ask, as far as the severe sepsis timeliness, is there a power plan in Cerner that allows, and this is probably a question for Dr. Bullock, that allows patients to just choose that and check all the boxes for a response to severe sepsis?
Okay, I would have to defer to either Felicia or Melanie that would have that answer. There is. Okay, there is. Okay. My apologies. Yes, there is.
And congratulations on all your safety of care and quality of care results for the month. Improvements in a couple of places. Thank you. Any other questions?
Just one question about the number of actual participants and to increase the number of participants responding to the survey.
Yes.
There's a plan. I'm sure that there's a plan in place.
Yes,
I think that's really key.
Yes, there is, and we are working with the marketing department as well as with the performance engagement or patient engagement to increase that. As we've noted in our monthly thing that we did go from 7 to 16, I believe, so that's more than double. So we intend to increase that as well, and I will defer to Kathy to give additional information regarding that.
So when it comes to getting those Press Ganey surveys, there's multiple ways in which they can be done. Obviously, phone, mail, text, and it's finding that sweet spot for our organization and our patient base to understand how they're going to respond to us and making sure that the phone numbers and addresses that we have on the front end are correct. And there's a lot of cleanup that we were working on throughout the organization, and that's something now that patient experience is falling back under our team because we have to have 300 in order for it to be statistically significant for a year. So that is being addressed and we'll be working, collaboratively between patient access, quality, and our team as well.
Yeah, that is quite a challenge because now, with cell phones and whatever, the whole thing, people are not going to, the internet on the computer or anything like that. So that you have to be clever ways and people
the
move
timing
around.
of it, making sure that they get the survey not 2-3 weeks after their appointment where they might not remember, might not want to even participate. It has to be sooner than that. And there's different price points and things that also affect that as well.
Exactly. Thank you.
Any further questions?
Thank you.
Thank you, Ms. Lewis. Okay. We will move on to committee reports, and in the absence of Dr. Miller, Mr. Lesser will give the nominating committee report.
Dr. Martin, can we approve the quality?
Yes, okay. May I have a
Motion.
motion to approve the quality report?
So moved.
Second. All in favor?
Aye.
All opposed? Thank you. Mr. Lesser, you're recognized.
Thanks, Mr. Chairman. Our committee met recently, and even though, according to the bylaws, we will not vote on the new slate of leadership at the board level until the June meeting, we wanted to report the results of our committee meeting. And in the vote, we recommended for chair 2 members of our board, Ms. Smith and Dr. Martin. Since that point, Dr. Martin has declined the nomination, so it is just Ms. Smith. For vice chair, Mr. Esquivel, and for secretary, Dr. Nettles. And we would put that before the full committee at the next board meeting.
Any questions of Mr. Lesser? Suppose we should approve the report of the nominating committee to hear such a motion.
I don't think we
No?
need to, because we're going to vote on that recommendation at the June board meeting.
Pardon?
Sorry. In order to implement or affect it under the bylaws, it will be done at the June meeting. So it's not a report that requires an affirmation.
Thank you, sir. We'll move on to the CEO Performance Review Committee report. Ms. Smith.
Thank you, Mr. Chair. Our committee met to review the fiscal year end June 25 report for the CEO. We wanted to make sure that we continued the process of scoring, discussion, and then ultimately at some potentially in the future awarding the CEO with a bonus reflective of the current structure, which was up to 5%. During the settlement process, it has been noted in our committee meeting that there's no further compensation due to Dr. Webb for his position as CEO, but our committee did feel the importance to basically go through the assessment so we could discuss the merits of the process, but also the specific areas of growth, financial performance, quality customer service, and then the board engagement. So we did go through that process. We won't belabor it, but we each go through, for all new members, we each go through a scoring process of 1 being unacceptable, 2 needs improvement, 3 average, 4 exceeds, and 5 consistently exceeds. And then each of us score, we added, and then of course, looking at the totality of that number would provide a bonus of, anywhere from 0 to 5%. So it is our committee's unanimous recommendation to the full board to not move forward with a bonus. Again, I would lean on Derek Smith, our attorney, with any questions about the legalities of the contract, but our recommendation would have been to not move forward with a bonus at this time based on, the financial issues that we've had, the audit issues that have come to bear, and I would just say culturally, kind of where we stand. So, Derek, are there any other comments that you might have to add to our report?
Based on my understanding of the contract, the evaluation by the committee has taken place. You've delivered the report of the recommendation of the committee. It would now be for the board to take up and vote whether to accept that recommendation or not.
And I would invite Mr. Escobar, Mr. Lesser to make any further comments about the committee meeting. Okay. So,
Mr. Escobar?
No, I don't have any further comments. Thank you.
all right. So,
This committee report serves as a motion, I believe. And is there a second?
May I ask a clarifying question before we move on to that? Was this, that determination or suggestion based specifically for our previous CEO and understanding the climate and culture and what we're going through, or even moving forward when we have when we have a permanent CEO in place?
yeah, that's a good question. This was specific to the fiscal year ending in June 2025. We also discussed, and thank you for bringing that up, Dr. Hudson, in going forward for fiscal year 2026, our goal is to stay on schedule and be able to provide to any new CEO prior to July 1st these goals so they can better adjust and obviously cascade those goals down to different leaders. We're almost there with the July 1st. We're going to be maybe a month behind that, obviously with understanding there's a current interim CEO, but we would like to get as an action step, a committee member Lesser recommended, obviously meeting with Dr. Elders to get her feedback now that she's been in the seat, and is there anything that she, or maybe even Dr. Blackledge with her experience now as CFO interim, could help with continuing to refine the goals and metrics for a new CEO in the future. We felt like that would be important as we get to the point where we are looking at kind of final interviews and hiring to say, hey, look, here's what's important to us, and here's how you will be judged with regard to the bonus. So I think that having a process, having those, this moving forward will be a great roadmap for that individual.
So there's a motion on the floor from the committee who has recommended not to award a bonus for the previous CEO for fiscal 25. Do I hear a second?
Second.
Any discussion? All in favor? Aye. Aye. All opposed? Thank you. Recognize Mr. Esquivel, the CEO Search Committee report.
Thank you, Mr. Chair. In the last time we met, we were contemplating how we would go about the process of selecting a search firm to assist the committee in finding our new CEO. It was up in the air at that point as to whether we could use an existing firm that we believe we had a contract with, or whether we needed to go out into the market, so to speak, with a request for proposal and figure out, engage in a competitive solicitation process to hire that vendor. With the assistance and investigation of Metro Legal into the existing contract, we came to the conclusion, or I should say Metro Legal advised the committee that we were in fact required to go out and conduct a request for proposal. So the committee adopted that recommendation from the legal department, and that process is now underway. For the board to know what that means as a practical matter is that for the next 2 to 3 months, roughly, we will be engaged in a public competitive solicitation process. That means we issue a formal document called a request for proposal. We invite people who are capable of providing executive search firm services to submit responses to that proposal. We evaluate those responses. We likely conduct interviews with one or more of the respondents, and then we select a firm based on our evaluation of their proposals. And at that point, then, we will have a search firm in place, and that search firm will help us undertake that process of meeting with stakeholders and community partners to help frame what it is that we want in a new CEO, and then go about identifying and recruiting and interviewing and selecting a CEO. So I've now gone through sort of the whole process, but for the board to know, the next immediate step is the RFP. Metro Procurement is going to work closely with the procurement function within the hospital to conduct that RFP. There's already a draft that is being considered and evaluated by the procurement professionals, both at Metro and at the hospital. And that process is underway. The committee will continue to monitor that. We'll have input into that. We'll certainly be part of the evaluation team that helps select that vendor, and that's where we are.
Do we have an estimate of, when the RFP process will be completed? Yeah.
Yes. Yeah, please.
So Metro Procurement and I met on Tuesday afternoon. We went through the initial draft. They have some specific language that they must use. So we're going back and forth. They asked me to get some questions answered. So we're going back and forth with a draft for the goal is within the next 10 days to have that posted out on the website for the beginning of the recruitment process. So just let you know that we did meet with them. I spent the hours with them going through and the information. So we should have that within the next 10 days. So it should be posted out there for everyone to see and apply for and start the process.
Thank you.
You're welcome.
Now I recognize Ms. Smith and Dr. Blackledge for a Finance Committee report.
Dr. Blackledge, go ahead and we'll run through the 4 items that you had here on our report. Thank you.
All right. Thank you, Mr. Chair. Thank you, Madam Finance Chair. We will begin with a brief review of the April financials from Keith Moran.
Good evening. April 25. I'm going to go over the our narrative that we sent out to you. So please, if you already have some questions, just stop me and let me know. Our patient volumes, the inpatient admissions, declined in March from 232 in March to 221 in April. But it was above budget of 220 admissions. Our observation visits totaled 211, which exceeded the budget of 174 and the prior month of 187. Our patient days were 833, which was below the budget of 868, with an average length of stay of 3.8. Our case mix index for the hospital declined from 1.28 to 1.21, falling short of the budgeted 1.31, which indicates a lower acuity of discharges. Our emergency room visits decreased to 2,155 from 2,252 in March, which was below budget 180 visits. Our surgical procedures inpatient increased 32 from the previous month of 27 and was above the budget of 27. Our outpatient surgery cases climbed to 115 from the previous month of 100 and was above budget of 87. Of course, the cath lab volume is still 0 at this time. Our interventional radiology cases fell to 18 from the previous month of 28 and our budget of 68 cases. Deliveries totaled 37, which was an increase from 32 in March, 6 cases above budget. Our monthly visit of, clinic volume visit was 4,511, which was down from 4,645 in March. Our year-to-date visit volume was 26% above budget, which was 44,482 versus the budget of $35,236. Sorry. Our patient revenues were $25.3 million, which was 10% below budget. Our inpatient revenue is 6.7% below budget, or $5.2 million, which is predominantly due to the cath lab underperforming by $4.1 million. Outpatient revenue dropped 13% below budget, which is also impacted by the cath lab, which was $5.4 million and $3.7 million in individual radiology shortfalls. Our net patient revenue totaled $5.27 million, which was only $97,000 below budget. Other revenues were below budget 18.5%, but this due was to a Medicare settlement of a cost report, which was a refund was done of $683,000. That was related to the 22 cost report. We also have a 23 cost report settlement that is coming up. It's approximately $850,000 payback. Our staffing expenses was $5.6 million, which was $674,000 above budget, but our total salary costs, which is salary, wages, benefits, were $7.8 million, which was $628,000 above budget. Contract labors rose to $742, which was a $473 increase, $1,000 increase from the previous year, but was still below budget by $334. Lease and utilities over budget due to various unbudgeted leases that we started this year, like Metro Center, different leases that we started this particular year. So overall, our total expenses were $12 million, which was $609,000 below budget, so that's good. Our net loss for the month was $1.1 million, and year-to-date is $19.9 million. Items that affected this year's budget is, of course, we implemented the Cerner system and the cost report settlement that we had and the cath lab. The remainder of this year, we will be getting the $9 million. We'll be booking it into revenue in May for the Metro subsidy. And also we'll be booking the $850,000 for the cost report. So as far as cash flow for the month, we were down $610,000, which is pretty good compared to the previous months that we've been having. But year to date, we're $8.5 million in negative cash flow. We also have a chart that we have here that shows how we spend our money. Right here is a breakdown by percentage. The in the center is the budget, on the outside is the actual. Left one is month, right one is year to date. So you can see we had lower expenses, other expenses besides salary, so that made our salaries and benefits percentage have a bigger piece of pie for the actual. We're over to the right, year to date, it shows you basically an average of how our money is spent. So any questions, comments, suggestions? So that concludes my report.
Thank you, Keith. All right, good afternoon again.
I'm sorry. I do have one note that I would like for you all to repeat that we heard in finance. Yep. The payback, or would you just explain that, just a summary, just so to understand the money we had to get back and the remedy that you have?
Okay. So the 22 cost report and the 23 cost report, when they were prepared, when they put in I'll be more specific this time, the census statistical data and all our payments that we received, the person preparing the report left out the IME dollars that we had gotten. So when we file the cost report, they send us extra money that we didn't deserve. So when they came and did the audit, they caught that, and then, of course, they requested for the funds back. Now, currently, and when we did the 24 year, it is all electronic now. We upload the cost report information electronically, so we make sure that doesn't happen again, because I don't like giving back money.
All right, thank you. And IME, indirect medical education expense. I'll go ahead and get started talking about, maybe we move to the budget hearing. I think that's what I need to cover in this one, and it's the payer mix update. Fueling the mission, which is really around our budget. I'll hold that right there, Mr. Chairman, if that is good, and not get into a separate budget update for the sake of time. And then lastly, if there's time, I'll cover our KPMG. What you have in front of you is our payer mix. So we were asked to look at the payer mix and look at it over a period of 3 years and break it up for patients that are in a bed, and then patients just come to us for some type of clinic service to see a doctor or a procedure or test, and then they go home. So what this chart really is a visual of is over the 3 year period, and for this year of fiscal year 2025, we're 9 months in at this period that we crafted this information right in front of you. So going left to right, if we look at patients that are in a bed that have insurance, we're up to about 70%. And if we look at patients that are in a bed year over year that do not have insurance, we're running about 28.4%. So what you want to see is you want to see your insured population increasing, and you want to see your uninsured population decreasing. And for those patients that fall into this population, many of them may come to us without insurance, but we do have access to programs to go and visit with the patient and see if they could qualify or they become eligible for certain state programs, and then we could be reimbursed. On the outpatient and for the outpatient insured, we are running about 68% year to date. On a uninsured standpoint, we're running about 30%. And so again, the trend is what you want to see. For your insured, you want to see that percentage increasing. For your uninsured population, you want to see that percentage decreasing, because the way we fuel our mission is by creating some type of income, recognizing we also have a charter. Some of the programs that we tie into include TennCare and include SSI. We can move to the next slide. And if there are questions, please. All right, let's maybe go back to the first slide.
I appreciate what you just said about the balance. It's about the business. But do we have any idea and I'm not sure how to even ask this, but in the general population, how many people are uninsured, so that we are not, I know we have to increase the revenue stream for the hospital, and one way specifically is through the insured patients. But by the same token, a fairly significant portion of our patients and potential other patients are uninsured. How do we make sure we're not directing ourselves solely towards the insured patients? Does that make any sense? I'm talking about
I can answer your
broader.
question in a couple of parts. It makes sense. But one thing is we fall under a charter, and our charter requests that we create a mission that supports the health and well-being of the uninsured. So that's one. From a trend standpoint, just in general healthcare, general society, the unemployment trend tends to be one indicator of what might be in your population that's uninsured. Many individuals gain access to insurance through their group health, through their employer. That's one. The secondary way that they gain access is through the exchange plan. The third way is that they gain access is by being really sick, like the population. On this slide, some of the population inpatient insured may have come to us because they were really sick, and they didn't have insurance, right? Because you can come to us if you're really sick and you don't have insurance. But one of the things that we do is we try to screen you, or we do screen you, to see if you have access based on your eligibility, meaning your income is X of the federal poverty guidelines. Based on a set of other indicators, we're able to assist you and attach you to some kind of insurance to be reimbursed. So while we don't have a holistic way, unless there's some kind of census or some kind of public data that we may be able to research and identify to say who's uninsured or what population. But we do know the population that we serve, that population, how many of those are insured or not insured. So to answer your global question, it would probably be like 3 or 4 trends that you would have to look at to kind of come up with a way to assess it. Yeah, that fair? All right, let's move to the next slide. Good question, by the way, too. It's good, a real good economics question. So let's talk about the payer mix, meaning those that have insurance, and the name of those companies or the category that they fall into. Left to right again, inpatient to outpatient again, and all 3 years trend. When we look at this, I'm not going to point out, certain insurance providers, but I do want to talk a little bit about towards the bottom portion of the chart, the Davidson County inmates. That population, inpatient, outpatient, is not reimbursed to Nashville General Hospital. And then you have the uninsured population not reimbursed to Nashville General Hospital. I want to point that out for a couple of different reasons. The second point I want to share on this slide is that when we think about our patient revenues, we talked a little bit about that as Keith gave the April income statement information. But about 27 or 28% of our inpatient dollars make up that total patient revenue. And then on the right side, about 70% of our business from a revenue standpoint is from outpatient visits. A couple of things that we do that have efforts in place. Kathy does marketing. She has press. She's spoken a little bit about that this evening. We also have what we call a growth plan. If you guys recall last February, I think of 2024, we brought in the Metro clinic. So when we think about clinic acquisitions or mergers, partnerships, then you have the other impact for us is unemployment trends. We just spoke a little bit answering the question that was put forth. And lastly is access to group health. So those are kind of some of the ways in which patients and others acquire insurance and the way we grow our business, and our intention for this upcoming year is to grow our business.
May I ask a question about this slide? I don't know if you're moving on or you have more, but I had a question about just the categories to understand what is contemplated by them. So to understand the Davidson County inmate, I think your next slide might hint at this. It's separate from uninsured.
Correct.
But I mean, is there any revenue to us from Metro or any other source, or are those essentially uninsured patients?
So the first part of that, they are essentially uninsured patients, uninsured population, right, is what I would say. However, the subsidy is what is utilized to cover the cost. And we're going to capture what I would call a snapshot of what that looks like and how it relates to the percentage of our uninsured patients and including the non-reimbursed care for Davidson County inmates. Is that fair?
Yeah, I think I understand it. So if you, I understand the subsidy would apply, but the subsidy also applies to the uninsured, I would guess.
Correct.
Right?
Both categories.
Okay. So does you have a formula to allocate the subsidy differently to inmates that come from Davidson County versus the general uninsured care that we provide?
No, we don't have an allocation. We don't have a formula. However, what I will share in the next 2 slides is how one segment of information connects to the subsidy. So how this population that we're not reimbursed for, how that connects to the subsidy by way of percentage for the whole piece. So the next slide, we can go ahead and advance to the next slide.
Before you do, I'm sorry, but just definitional. So there's a category for Blue Cross.
Yes.
And then there's a category for commercial. Can you help me understand What is
Sure.
contained within Blue Cross? What is contained within commercial? And why is Blue Cross as a payer singled out by name in a way that no other commercial payers or any other kind of payer is paid out?
Right. So typically, your Blue Cross is separate on its own. Typically, you do a lot of volume with Blue Cross, and so Blue Cross typically always in your payer mix is separate on its own. Now we can, if we choose to, break out the commercial piece, but we keep our commercial lumped all together. And what it is you're looking at everything outside of the Blue Cross. Blue Cross typically runs most states, so it stands on its own. And then in commercial, you're going to have Ambetter, you're going to have Cigna, you're going to have. I heard somebody say something. What did you say? Okay. I didn't hear what you said. Okay, I was getting ready to say, I was just calling out some of the payers that you're going to have in your commercial category, but it's pretty much customary to have your Blue Cross standalone because they are a major player in majority markets. And then you have your commercial, which will be outside of that all lumped together.
Okay. Yeah, I agree. And maybe it doesn't make sense. Although fiscal year to date, the combined other commercial is nearly 24%. Blue Cross is certainly a large payer in our state, but for us it's 5%. I just question whether, I don't know that we need to see it by payer because there are a lot of payers.
Well, that was one item I brought up. Do we really want to get to that level of detail within this forum? But we are here today, and we are here now, and
well, this is mostly just to understand what these are.
Absolutely.
And I agree with you that like seeing 15 different payers is probably not helpful.
Not good.
Question about, you've combined Medicare and Medicare Advantage.
Yes.
What is in general, I know that it may be specific if we're in network with Medicare Advantage provider or payer. Is there a difference in payment rate generally from traditional Medicare to Medicare Advantage?
Yes.
And what is the difference?
There is a difference in the payer rate, and so what you're going to find on the Advantage plan is what you choose to negotiate, right? Mm-hmm. Because those are plans that we are negotiating. So there is a difference between the two, and the administrative rules are very different. So you can get into an increase of denials, authorizations, all of what I call just administrative red tape. That is very different from your traditional Medicare plan to your Advantage plan.
Do the Medicare Advantage rates that we negotiate generally higher or lower or more in line with traditional Medicare?
They should be slightly higher.
I asked that leading to this question, which is whether combining Medicare for this purpose, which is to figure out the payer mix, whether combining Medicare with the Medicare Advantage, is Medicare Advantage more like commercial or more like Medicare?
More like commercial.
Yeah, that's what I thought. So it could be, it might be helpful not to group those two together. Maybe MA is a separate category, or maybe MA and commercial makes sense to put together, because I tend to think of those as that, and MA as a commercial payer.
Yeah, and you could group them different ways for the purposes of sharing an illustration to what this might look like and what it is over these past 2 years and this current year. This was the illustration that we went with. Now, what we did not want to get into was getting to that secondary or tertiary layer of transparency in this type of meeting. Mm-hmm. Now, if you would like to go one by one, we could share that with you in a one-on-one session as a board member, and you're welcome to join us for that session.
I appreciate this may be more detailed than anybody wants to hear about. I have one final question, then I'll be quiet. There is there any appreciable volume or reason for us to have information about commercial payers, Medicare Advantage payers that are where the patient is in network versus out of network? Do we have any amount of what we're seeing in here are out of network, or is this all volume based on negotiated contracts with these payers?
No, you're going to have both in network and out of network. Right. You probably have less out of network, would be my guess, without going into the detail. And obviously, I don't have it right here in front of me, but you should have less.
all right, that may be a one-on-one session that I'd be interested in, but for the board, this would be a separate chart, which is to understand.
In-network versus out-of-network?
Well, I think there's different, like, the reliability in there. It'd be interesting data to have to understand what that looks like.
Yeah.
Because I think it has financial implications.
And it does, and,
Yes.
and it's definitely interesting to look at it. You can look at it multiple different ways, and that is one way. That is a more granular level way of looking at it.
Great, thank you. That's very helpful.
Can I just say that I asked for this report primarily to look at uninsured versus insured patients and how that compared to the percentage of our budget that is supplied by the Metro subsidy. And I think Dr. Blackwell is just going to get to that point.
All right.
Doctor?
Sounds like permission to move, right?
One more kind of tangential question.
Okay.
On the Davidson County inmates, do any of them ever have coverage?
There may be. I want to probably reserve that.
Not while they're an inmate.
Okay, that's what I was going to say. There may be. Okay.
Sorry, I'll answer. Not while they're in Davidson County custody. Now, if they are released, we automatically go back and check that bank to see if they have insurance. But if they are in custody, we cannot. They are in the custody of Davidson County, and that's just it. When they go free world, that's when that insurance check, and then we can apply, but it's only from that moment of discharge from the police. Because we've had that incident several times, come up mid-hospital stay. And so that's how that works. Yes, sir.
Thank you, Dr. Elders. So when we move to look at what does this payer mix look like for the current year that we are in, if we just holistically step back and look at it, including inpatient, outpatient, whatever. This is a snapshot of what our current payer mix looks like. I want to draw your eyes to the bottom portion of Davidson County inmate at 4.05, and then the uninsured population at 28.8. And so if you look at that, that's about 32.8. And so when you think about that, that's about a third of the population. If we move to the next slide, we're going to talk a little bit about the subsidy. The subsidy that we have received is $60.7 million. Our total income, if we look at a picture of where our income, where it actually comes from. And so when we look at that, we've got $158.8 million, 38.2% of that is a result of our subsidy. And so when we think of that as we reflect to the slide just before, where we saw about 32.8% is related to our inmates in Davidson County and then the uninsured population. So when you think about that and how we connect that, a good portion of our dollars through the subsidy piece actually falls right in line with the charter to support that piece of the mission. And so that was the intent of this exercise, is to look at our payer mix and then tie that to, well, how does this fit with fueling our mission and what does that look like? So this past Thursday, Dr. Elders, myself, a team of Nashville General Hospital employees, we participated in our budget hearing. Our initial request was for $66 million. I understand that that request was made in February of 2025. We were granted $60.7 million, and that's in this slide over my left shoulder. Along with that $60.7 million, the other dollars are made up from a few different buckets. Net patient revenue, 67.4. That's made up of the dollars from the patient population that have insurance. We looked at that just a few minutes ago. So those dollars collected, that's where we'll get the $67 million from. We have some other revenues. Some pharmacy we opened up in the Metro Clinic, we opened up a freestanding pharmacy there. We have some radiology dollars from our School of Health Professions. We have Medicare cost report. Then there is additional state funding and then some DISH money. And so that kind of serves as our source of income to really share that with this audience and tie that back to our payer mix. The other thing I want to really share too is we meet with Metro Finance We host monthly meetings, and then there is a weekly meeting that many of us participate in. Part of what we have not consistently did in the past is apply for some of the 4% funding. So our intent this upcoming year is to be proactive. We already have initiated those conversations. So we're in a good position to be prepared to submit the documentation information that's needed to support the organization.
Doctor, how consistent is that additional state funding year to year?
So if you looked at your income statement, we actually did not include the $10 million that we had questions about over the last 3 or 4 months. And so this is really consistent. We received it prior months. And I think we have 17.7 million to date received. So we're good.
Versus previous years and what we would anticipate next year, is that something that is purely the result of what the legislature does every year?
Yes, this is the program that that has been consistent with serving as an income source for us and us receiving those fundings. The question that we have had for us was the question around the 10 million, and we did not budget that this upcoming year. Just for pure clarification, we did not budget that 10 million.
And the funding in that program from the state is a program that reaches, that's not specific, they don't specifically allocate those dollars to us, do they?
Yes.
As part of the larger program?
That's part of a larger program, but we are recipients of those dollars. They've already had an initial meeting, I believe.
And how are we represented in making our case?
There's paperwork. So there's paperwork that our finance department completes annually and submit and participates in meetings. And there are timelines associated with this funding piece of it. But it's customary, it's standard operating items for us.
If I may, so the additional state funding, the Tennessee Hospital Reinvestment Program is what she's speaking about. Yeah. Now, originally, so for this year, which is one of the reasons it's up in the air for whether we're going to get that money, is because they changed the programming. And so right now, they are in communication with Dr. Blacklist to make sure we're meeting our, what I call benchmarks, to ensure that when it's decided or when they officially approve the program, that we are in line to get our share of that state dollars. So it's a formula that the state has in who they award those monies to, but it's THA is helping sponsor that program, and we've been in constant communication with those people.
We have a legislative champion?
Not necessarily a legislative champion, but we have contacts with THA, and I know Christy's been in contact with THA. This is being led by the Tennessee Hospital Association, and it was just a change in that state funding program. And so they made the change. We're almost at the finish line of it being approved, but what we get and what our future looks like is still up in the air because that program was changed, and it's called the Hospital Reinvestment Program.
And on that note, I have asked Lacey Blair with THA to come in and do a board education for us I think, that would better help educate all of us who are not into lobbying for our living to better understand what is the current atmosphere, helping us understand how that funding is tied in, how variable it can be, what are the triggers, but also what can we do, in terms of if there's an action step or something that we can do to be helpful to get that across the finish line. But I think, she has graciously volunteered to do that, and so we are in the process of getting her on the agenda for.
And that's all great. I would hope, though, that we would have champions in our state senator and our state representative who could speak on our behalf during budget discussions to make sure that we are not forgotten in the broader mix as they think about other hospitals in the state in total. We want a strong voice.
I'd echo that. We want a strong voice. All right. Any other questions around how the dollars that we receive fuel our mission? All right. Okay. Let's go. KPMG update. Mr. Board Chair, do we want to proceed with the KPMG update? Just want to make sure.
I think it'll be let's table that until next month.
All right, thank you.
And recognize Dr. Elders, discuss Midtown Clinic.
Yeah, so I'd like to bring up one of our difficult decisions that we are faced with making as we look at our cost effectiveness. 1919 Charlotte Avenue is our Nashville Healthcare Center Midtown Clinic. We were at the state to where we would have to bring the lease renewal to the board to renew or decide if we're not going to renew. It's a 5-year lease. Operating at the operating margin has been at a $2.5 million loss for 2024 and 2023. And when we looked at April 30th of 2025, an operating margin loss of at 1.7. And so we're really looking at a year-over-year loss of greater than 1.5 million. And so we are looking to make the decision not to renew that lease, which would have needed to be renewed by May 31st. And so we wanted to share that information with the team. We did ask for a lease extension through June 30th to wind down and perform all the necessary structure and logistics that we need to do to move the physicians and notify the patients for that clinic.
And Doctor, part of that moving forward would be, as you, I think, referenced, making sure that the patients who have or are currently utilizing that facility know what their alternatives are.
That's exactly why we've done the 1-month extension, and that's the activities that are taking place right now through June 30th. The providers, there's 2 providers that are in there, and a few specialties. So those specialty providers will still be deployed to the other locations, which is Bordeaux and Metro Center. And the 2 primary care providers, one will be at Metro Center and one would be at Bordeaux. And then we're notifying the patients of the location change. Any other questions around that?
The providers who are being deployed to the other locations, is there a capacity to absorb that, or does that? I guess what I'm asking is, are they going to take appointment times available from the existing providers in those locations, or they are just going to add on top of the services already being provided?
We're adding, and there's room for them in those other areas. One of the things I think we've talked about is Bordeaux and ensuring that we're getting, the most bang for our buck in that clinic. And so we'll be placing another primary care provider in that clinic. And then there was a need for a female provider at the Metro Center clinic. And so Dr. Patel, who was at Midtown, will move to Metro Center.
Thank you, Dr. Elders. Any other questions? If not, we'll move on to the contracts. Ms. Smith?
Okay, thank you. I'll run through these contracts real quick, if it's okay with you, Mr. Chair, just to try to be efficient with our time. The first contract was KJ Trauma Consulting, presented by Dr. Elders. This is a consulting contract that has been in play already. It was part of the audit finding, but it is a registry for patients who have been injured. And as a level 3 trauma center, we're required to maintain this. It is a auto renew contract starting on 5/30/25, ending on 12/31 of 26, and the cost structure is for last year was $4,869.75, but the pricing varies based on the actual hours worked. So there's a breakdown in your packet that talks about the year-over-year changes. But our committee had the opportunity to discuss this at length with Bill Campbell, the trauma program manager, and recommends unanimously a full approval by the board.
Hear a motion for approval of this contract? Second?
Second.
All in favor?
Aye.
Aye.
All opposed? Passes.
Second contract presented by Aisha Cooper Colquitt, I'm sorry, she was not there, Julie, I'm sorry, who was manager of GI and the Endoscopy Center. She was our presenter. Again, already in play from the internal audit is an issue, and this, by the way, noted that cleans up our internal audit issues on this specific outstanding contracts. This is the main purpose of the contract deals with a liver health assessment tool. The cost of the hardware, $45,000, and then there's some maintenance fees. There is an estimated 3-year revenue of about $178,000. And it's like an ultrasound, and it's basically a 20-minute outpatient procedure. This is a contract started in August 17, 2023, end date of August 17, 2026, and a cost of $26,280 a year. So this is device and services needed in the GI clinic. Again, our committee recommends unanimously to the board to approve.
Any discussion? We did have a presentation by someone on the clinical side to explain to us why this is important, and we'll try to do that with clinical decisions going forward. Do I hear a motion for approval?
So moved.
Second. All in favor? Aye.
Aye.
All opposed? Passes.
May I make a note that we did not vote on the very first one, please? We went through the part where we didn't say, we didn't vote all in favor. You left that piece out.
I think we did.
Did we?
On the first contract.
On the first one?
We did. Yeah.
I'm sorry I missed that.
All right. But
Really,
thanks for
didn't get a
holding us
chance-
accountable.
I didn't get a chance to say aye. Okay, all right.
There's been a lot of ayes lately.
Yeah.
Next up is the trias. This was presented by Dr. Mark Brown, and this is a waste management contract. In short, this came to us in a previous board meeting, but we had asked as a board for Dr. Brown to go back, receive some other bids, which he did. We found out this company proposed the cost structure for this year is going to be about $179,000. He felt like this contract cost and specific vendor was a more holistic vendor, and the other two had a more limited service model where you had to, I think, piecemeal some things together. So this is disposal of medical waste and services as well as paper waste. After discussion, our committee recommended unanimously to approve this and move it to full board.
Any questions? Motion?
Move.
All in favor? Aye.
Aye.
All opposed?
Next contract is BedWatch, also presented by Dr. Brown. This was discussed as well by Melanie Thomas, who's our Chief Technology Officer. The goal of BedWatch is to optimize the use of hospital beds, and this is obviously a technology piece that we thought at one point would be implemented during this Cerner implementation, but it looks as if that option was not as functional as BedWatch. We have used this company before, so the decision was made to go back to this company. The cost is $52,416. Start date of 5/29/25, end date of 5/29/28, and there is some credit which was brought up by, I think, Dr. Hudson, that since we had paid for this as a function of part of the Cerner implementation, that savings was going to be credited, or I guess, or has potentially been given back to NGH. I'm sure they will track down the dollars if we don't have them. So again, recommended unanimously by the full board by the committee to the full board.
Interesting name for a company.
We need to discuss
Says it
that
all.
part. I did ask if there was any extra cost if the number of beds in the head goes up, and they said no. So, good there.
Any questions? Motion?
So moved.
Second? Thank you. All in favor? Aye.
Aye.
All opposed?
Last contract is compliance line. This was presented by Christy Lewis. This contract. As the vendor will conduct exclusion checks on behalf of the hospital. This is needed, and you'll have to lean in, Christy, if I have any questions on this. This contract start date was 12/19/2024, goes until 12/18/29, and the total cost is, it says here, proposed annual cost $7,370, but it looks like an annual increase. I wrote down the price of $9,270.19 in total. I'll be honest with you, I'm not a pro on what a compliance, I'm sorry, an exclusion check is, but she did feel like that the volume of that need, I think, would be serviced by having this vendor specific to what is needed to perform the duties. I don't know if she wanted.
I'm sorry, she had to leave.
Okay, that's okay. All good. So, again, unanimously recommended to this board for full approval.
Somebody may know better than I, but I believe the exclusion checks has to do with making sure that all of the providers, none of the providers are have been excluded from Medicare or Medicaid or anything like that.
There you go.
In the interim. So, has to be done.
I missed writing that piece down, so
All right.
thank you.
Do I hear a motion for approval of this contract?
So moved.
And a second.
Second.
Thank you. All in favor? Aye. Please. Thank you very much, Ms. Smith. Board Chair report. I would like to commend Dr. Elders and Blacklist and the whole team for moving us through this period with response to the audit and to taking a close look at our expenses and acting accordingly. And it's been a tough time, continues to be, but we're seeing great leadership. And I think that we had hoped to move forward with the CEO search more quickly, but the good news is that we've got great leadership in our C-suite right now, and we've got time to do this like we should. I'd like to remind everybody that we have an important election of a stellar group of officers. Electing these officers requires a majority of the 11, even though we only have 9 board members right now. So I would emphasize the importance of attendance at the meeting in June so that we can get that done. And with that, I'll turn it over to Dr. Elders for the interim CEO report.
Thank you so much, Dr. Martin. Some of these things, there is an interim CEO board report in your packet, and I'm trying to do that at every board meeting so that you could have something tangible to look at. So I'll just mention a few things that haven't been mentioned yet. One, on June the 1st, we'd like to invite you all to join us for our cancer survivorship celebration. It will be here on the 11th floor. We provided an update on the PSA already. I will say also, since that time, I was invited by Dr. Hilders to attend the Meharry Medical School Board of Trustees meeting on Friday, May 16th, and went and introduced myself and our vision in a partnership of moving forward. As we talked about with the Metro internal audit, we only have 3 outstanding compliance items. The contract that were presented and approved today, when we send the link to the investigator with the recording of these approvals, that satisfies that. We are also looking at the legal action for recoupment of overpaid funds to City Valet. We did receive a notice of conflict of interest with our current legal representation, so we'll need to seek legal representation elsewhere for this matter, and Christy Lewis, our compliance officer, is working on the litigation process for that. Lastly, our leadership mandatory education on our new contract system is due June 2nd. That is for director level and above. And once that June 2nd date and we send over the roster of completed education, we would have satisfied all recommendations for the Metro internal audit, and we'll just be awaiting for them to come back and visit us to ensure that we've maintained that compliance. In regards to stakeholder relations, we've held several meetings. We did have a meeting with the mayor's office, did meet with VUMC. There's a meeting scheduled with Ascension. Dr. Bullock and I met with the Nashville Fire Department chief, and we have a plan to meet with the MNPD, Metro Nashville Police Department chief, as well as their community stakeholders. And we also interface with them through our emergency department quite frequently. I would say, as they noted in the finance report, salary expenses continue to be over budget. Now, we have made progress with our contract labor expense, and we are working on a corrective action plan. It's in implementation already. There are difficult decisions that are being made and will continue to have to be made, so I cannot stress that enough. Revenue deficits, they pave the way for growth opportunities and consolidation that we need to achieve while maintaining patient access. Dr. Blackledge mentioned KPMG, and we were asked to hold that for the next meeting. And then, Cece, if you grab that butterfly. So Chelsea Napier, who's right here, wasn't here. She couldn't make it, but as you see, y'all, she's pregnant. And so we'll give her that. But her award is in recognition of exemplary, exceptional leadership in implementing change. And so Chelsea's the director of our forensic health services. And I'll tell you, she took that program and made it her own with very little or minimum direction, because I've been busy. So, Cece, if you can give that to her. You got it? Okay, thank you. Thank you, Chelsea. All right, thank you so much. Oh, yeah, let's get a picture. Come on, Pumpkin. Yes.
While we're doing that, do we have a request for closed session? So we've had a request for a closed session for a marketing strategy or a strategic plan pursuant to Tennessee Code annotated 6811-238. This requires a roll call vote of the membership to convene that session.
Okay. Esquivel.
Yes.
Lesser. Martin.
Yes.
Nettles.
Yes.
Enzarue. Yes. Smith.
Okay.
Can I also ask that they leave their conflict of interest forms, and I'll go around and gather them?
And I do have one, I apologize, one more thing that I need to announce. So I won't be here June 20.
Yes, recognize.
Oh, I'm sorry. Okay, excuse me.
So,
on my phone, but you're required to speak.
all right. That no other, okay, I was going to say that. Thank you very much. But there will be no other business conducted in this meeting after the closed session, except for adjournment of the meeting. And before we convene it, go ahead.
I was just going to share that June 26th board meeting, I will not be present, and Dr. Bullock will be taking this seat and providing our report for the CEO. Thank you.
Thank you. And we'll now convene the closed session meeting, marketing strategy and strategic plans pursuant to Tennessee Code 6811-238. Please sign your disclosure forms before you.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.